Welcome everyone to the third weekly CTS ICU surge meeting. Previously we had discussed oxygen therapies and high flow nasal cannula. My name is Asha Devereaux and I'm a past president of CTS and have been part of disaster responses in the past. And we thought that along with Drs. Dennis Amundson and Dr. Christian Sandrock, we've been working together on surge preparedness for over 15 years. And unfortunately, the day that we had envisioned has happened over the last year. And we thank CTS for hosting this because it will be very important to know what our neighbors are doing so that we can troubleshoot things in real time. So this is your forum. In order to have this forum, we thank Fisher Paykel, SmartVest, and Ventec Life Systems for helping support this platform for us. But really, this is not an industry mediated, this is a non-CME event. This is really just a way for all of us to connect with each other. So for this evening, as with previously, we'll just do a round robin and talk about kind of what's going on in your ICUs. And I want everybody to feel comfortable. Even if you haven't let us know that you're gonna speak up, Dr. Amundson and Sandrock will help run that portion and they'll kick it off and then we'll hear from anybody else. And then tonight's topic is all about Ecmo. And hopefully we have Cassia Yee and Julian Ainer from UCSD and Scripps who help put together San Diego's Ecmo Consortium. If not, then Dr. McCall will help fill us in and bridge that gap. They're very busy tonight. And then Dr. Hugh Black from UC Davis will be discussing cannulation transfers and also guidelines. And then maybe we'll blend in Dr. McCall or Cassia will come back in. So however, we'll just be flexible and he'll discuss more about ECMO and avoiding crisis. And then if time permits, we've been meaning to talk about surge and staffing and team nursing, and we just can't keep getting to that. So humble apologies, but it is something that that is on everyone's mind. So with that, I'd like to pass the baton to Dr. Dennis Amundson from Scripps in Southern California and Dr. Christian Sandrock from UC Davis. Thank you. And now I'm going to be on mute for the rest of the evening.
I doubt it, Asha, but give it a whirl. I thought we'd start south and go north. I hope there's somebody from the LA area north. I just came back yesterday from the Fresno area, the Yosemite area, after that 120-mile-an-hour wind gust that went through. And if somebody was up there, I'd love to hear more from that area too, because there's certainly, it's everywhere in the state. In terms of San Diego County, as of now, we've had over 220,000 infected, and we've got 2,222 deaths at this time. As of 11:43 today, in our Scripps system, which, as you remember, is a 5-hospital system, we had 427 in-house COVID positive. That's relatively flat over the last couple of days. 107 of those are in the ICU, most on mechanical ventilator. And I think Dr. McCall is going to give us the ECMO data, but I know we're chock-a-block full on there. We've been ranging somewhere between 96 and 120% of our licensed beds, which means that we've moved out of that into other areas of the hospital. In our case down in Chula Vista, we've managed to get from 24 beds to about 28, going to 35. Right now we have 27 people in the ICU, all of them, the vast majority of them, I'd say 90% are COVID and 90% of those are intubated. And we're kind of seeing a leveling off, although our level off, as we talked about before, when you're talking about 22 or 20 long-term players in ICU, really cutting your effective ICU down from a 28 bed down to a 10 to 12 bed unit, it certainly puts a crimp on us doing business on a daily basis. And I will tell Dr. McCall to his face, because I can see him, that we really appreciate the mothership taking our transfers, taking some of our toughest cases, and certainly taking our Ecmo cases. And I really appreciate, that's been one of the more collaborative things that I've seen develop, and it developed relatively quickly when the need arose. So I think, again, I'm interested in hearing what you got to say, Scott. We'll talk about that later, but otherwise I'll go north and see what's going on up there, Christian.
Yeah, we're probably, for any of you who attended the call last week, we're pretty similar to where we were last week. Our numbers are relatively flat. Part of what's fooling us here is a push mostly by infection prevention to lift isolation on patients who've been in for greater than 20 days or have 2 successive negative tests. So what that gives us, and what gives our authorities and our MOAC, is a sense that we have less patients, but that may not be the case. You may be in our ICU intubated for 30 or 40 days. That's still a COVID intubation, but it doesn't always show up on our dashboard. So that's been a little bit fooling. Very similar to you, Denny, we're hovering around 110% capacity. So at any given time, we are still mostly using the ED and a couple of our other non-traditional areas like the PACU to hold on to some patients for a while, but we haven't burst into our main new surge areas. We have gotten some relief from our hospitalists who have been willing to take some of our trach patients on mechanical ventilation, and that's helped us out a bit in the ICU on the floor, on one of our floors where we have enough gas flow to provide. So that's been a nice change over the last week, I would say. Anybody else from Northern California, if they want to chime in, we're pretty consistent across other hospitals. Obviously, the data we get from our MOAC is not as reliable, but the ability to have free ICU beds is very scarce. There's a couple in the Sacramento area in Northern California, but really not many. As far as ECLS or ECMO therapy, we have a few cannulated people. We actually have, I think, 1 or 2 circuits left when we include the 2 backup circuits that are available for the 2 locations we have ECLS. So we're at near capacity for that, and that's limited our ability to take transfers, which Dr. Black will probably mention a little bit more about. And other than that, we did do a drill for our crisis standards of care last week, which Dr. Black is also a part of, and that went reasonably well. But as always, the gaps are higher up with leadership. It's just much tougher to get bioethics, compliance, legal counsel, and our CMO in when we're already so busy. So that's going to be a test we're going to work on next week, is our higher level above our triage officers and everything that we do at the bedside. And that's really about it, unless anyone else has thoughts from Fresno North. Feel free to chime in.
Anybody out there that has other information? I still have my post-COVID cough. Kind of sticks with me at times.
I wish I could do the same. Mine's just a smoker's cough. So there you go.
Yeah. No, we don't have to talk about that here. So let's drift back south then, if there's nobody in between. And we're blessed. I think, I certainly think I am. And I also think everybody's doing yeoman jobs, ex-Navy. That's what I got to say. Everybody's doing, 110%. And everybody gets a kudu. But I do want to shout out to Julianne Eigner, who I don't think made the call, who's the Ecmo coordinator that I've had the most interaction with. And it's what an incredible job to be available 110% of the time, to take the phone calls at any time. I think she probably by now has her cell phone embedded in one of her ears, because it's just, and it's the way it goes and the speed of which we find out candidacy and make arrangements for transfer and get the right people at the right spot at the right time has been gratifying to me. And I know that team is led by Dr. Scott McCall, who's on the line with us, and but not only the head of the critical care at our mothership in La Jolla, but also took on the Ecmo yoke, I guess is what I'll call it. We're excited to have you, Scott, and I'd be really interested in hearing what's going on the Ecmo side and some of your pearls that we've been talking about over the last day. So I'll turn it over to you.
So thank you, Denny, for your bounty from the border. We've appreciated it month after month. I remember a phone call early on was just call and let you know it's on. There's a procession of ambulances coming down the street from Mexico. And that was July. That's when we really hit it hard. And unfortunately, our coordinator managers can't be here, but there's a longer history, and maybe just go back a little bit in terms of what our hospital is about. I mean, Memorial basically runs 59 beds. We're running 77 currently, and then backing into the emergency department with 4 to 6 beds. In the ED, we can manage and continue to treat critically ill patients while using a limited number of ICU nursing, but also bringing our ED nursing up to speed to be able to manage folks on mechanical ventilation, et cetera. Sometimes they're downgraded or upgraded from there and they're able to leave the ED, but it's a way, I think the concept of a ED resuscitation unit goes a long way in any ECMO program to know that from the time they come in and begin with ED physicians who are more and more often critically care minded in terms of point of care ultrasound, intervention, et cetera, or emergent cannulation, that they continue, that nothing stops, that it continues no matter how long they have to wait there. So they're not boarded there, but they're virtually being managed as ICU patients in the ED. We haven't had to back into it that often because, again, we're running 77 to 80 or so beds. And unfortunately, a lot of our procedures are way down. I mean, we're a pretty big cardiovascular surgery unit, and we can't do more than 2 a day at this point, and several days with none. But it is a hospital that has an LVAD program. It's more of a destination. We don't do transplants. A lot of mechanical support capacity, though, various types of Impella. And with that sort of heart failure service, we grew as a VA sort of entity. And then in influenza seasons would then go on with more VV. And traditionally before COVID, it was more bicaval than anything else, the traditional Avalon catheters. But with the COVID ARDS and the sort of cardiac outputs they have, sort of vasodilatation that you're up against, we've pretty much relied on just VV bifemoral, both femoral, sometimes femoral and SVC. We've once or twice used a Protect Duo, and that was really just to bail out a more severe RV failure. So yeah, once this thing hit, we began to look at across the county, what do we have resource-wise? What kind of stuff do we have to work with? And because there was a relationship between UCSD and Memorial with Cassia and Julianne, that was a natural fit to learn from each other. So then the idea came about, well, 5 hospitals, you got Radius Children, you also got Balboa, but the main ECMO centers are through Sharp, UCSD, and Scripps. Take on what we can manage in terms of numbers and distribute them well enough. But so the first step was criteria. As a county, we're going to agree on exclusion criteria. We're going to agree on what population is going to become absolute exclusion criteria. All the time conversing about the mistakes we made or what kind of candidate we should have gone for, and the discussion, which I'm going to get to later in the clinical side of things. What have we learned about the best candidate? And what's problematic, I think everybody's seeing, is that it's a commitment of time. And once you have that, and you continue to have more and more and more cases, that's going to push you to that crisis where you're going to have to decide about what's the greater good. So early on with this consortium, we also had ethicists come about in terms of what was appropriate in terms of criteria, but also how we should behave as we hit 80% capacity. And since December 29th, we've been above that. We've stretched our own hospital. We wanted to stop at 8 circuits running at any time. And we have 12 available all the time. Now we've put 9 on, but we're starting to get to this point of really being full in terms of what we can manage in terms of bed numbers predominantly, but also staff. We're also pretty lucky to have perfusionists available for much of this. We don't use nurse specialists as perfusionists as yet. So to go back a little bit, what happens in the process is we get referrals, and when they come to scripts, I and Ayana Boyd-King, we're both pulmonary intensivists, we'll screen them with our coordinator, Julian Agner, and determine whether or not they meet inclusion criteria. So you have an objective couple of physicians making that decision. So that's been very worthwhile. For me, the experience is great because I get to look at the clinical phenomenon across the board. I get to see and look at what is happening to COVID patients to a greater scale than I would have had I just been working in the ICU. Going forward, though, if you do get into a reallocation issue, there's another phenomenon. So there are non-treating group of physicians who are expert in ECMO who would be drawn upon to present these particular cases within our hospital, but also compared to the other 5. So the entire population of the county, when we ever get into reallocation, will be looked at and then selected depending on which hospital that patient may have to come off. We haven't gotten there. We've tried some examples. We know what we're up against, but we have a well-defined process should we have to fall into that, and hopefully not. In the main, it's just been stretching to make it possible. That being said, when beds are available in one place and not another, it doesn't matter what health system you belong to, which hospital you come out of. We have letters of agreement to go from from a Sharp hospital to a Scripps hospital or the other way around. That's been pretty good. UCSD has the capacity to cannulate, go to any place, cannulate, and bring them back. The other night we did the same. We're not quite a mobile ECMO unit, but we have a very high sophistication in terms of critical care transport. That is to say, we can transport on any mode of ventilation with inhaled deletery or those sort of things. So it's been great in terms of managing a population, but even better in terms of being able to do a Zoom, present a case, also know that when we're looking at potential transfers, we can rely upon another group of physicians to also consider, should you go that direction? So that kind of decision making is hugely supportive when you get into some of the moral quagmires around this. But that's the short on the consortium per se. What I kind of wanted to get to, since we have other folks online, it's a little bit of the questions, the kind of things that we don't really have answers for. And I can sort of give my own opinion about situation. But one of the selection criteria has always been days on mechanical ventilation. The older, H1N1 sort of phenomenon, 6 days, 7 days. We extended it to 10 days. We're not sure why. But I think that it depends on what kind of ventilation you're on. You're trying to assess what degree of injury. Then 2, many of us look at non-invasive ventilation as ventilator days. That's the other question for the group. Do you also, if someone's been on non-invasive ventilation continuously or most of the time, does that count as a ventilator days? When you look at animal models of lung rest versus, complete lung rest versus low volume ventilation versus standard ventilation versus sham, even at 24 hours in a pig, you're going to see areas of lung injury, even on low volume. So I think the folks at NYU that were cannulating, by day 3, they saw some pretty good outcomes. And I think days on is a really important measure. We'll exclude just after 10 days. But then parenthetically at the university, when they had someone in their 30s and they were a lung transplant candidate and they were 18 days on, they went ahead and cannulated. That patient got decannulated, even though they were on 18 days. So some institutions, I think, would say, if you are controlling their mechanical ventilation and you've gone through a strategy to minimize your ventilator-induced lung injury, then perhaps you can go and do as well with 6 or 7 days. And people can answer to that, but I think that's been part of our issue, is trying to understand how they were ventilated up to that point. Another question, though, two that I'd be interested in is, when you go on ECMO, do you go to full lung rest, that is near apneic ventilation with a minute ventilation of less than a liter? Do you ventilate? Do you move on? Have you extubated someone on ECMO versus decannulate and continue to go on with mechanical ventilation? Those are variations in strategy that change throughout the country. Ours is mainly about getting decannulated, freeing up the ECMO machine and going on. And we tend to use the traditional near apneic ventilation, where you go to 10 or 12 a PEEP, maybe a rate of 10 or less, and inspiratory pressures of 10 to 15, forming dense consolidation and hopefully preserving that lung so that once you have a resolution, they improve and come off. That commitment is difficult, because now you're talking 6 weeks if you're really, really lucky, maybe 3 months, maybe longer before you can really decannulate. So yeah, I'm really interested in other folks' experience with that. But thus far, that strategy commits you to a number of patients for a prolonged period of time. And the end result of that is you're going to get closer to crisis care down the road. So that's one, was really around mechanical ventilation. The second thing I think that I'd like to explore is how you mobilize these patients, how you wake them up. What are the sedation strategies that work or don't work? What do you use paralytics for? And traditionally, people found early part of ARDS, full paralysis, that was a benefit. But the concern about what are you really doing is presumably stopping self-induced lung injury by diminishing inspiratory efforts. Subsequent to that, there's other studies around partial paralysis, allowing spontaneous ventilation. So part of our strategy really is, most of these folks are paralyzed coming in because of the severity of their hypoxemia and difficulty ventilating. But then where do you go from there? And there are various strategies in terms of withdrawal from paralysis, but there's also this propensity for continuing it beyond those 48, 72 hours, trying to give you your best oxygen delivery against consumption as a number, as opposed to moving towards awakening. Awakening is really hard to do when your chest wall is not moving and you're not seeing a tidal volume above 50 cc's. And this is basically what we would call a drowning syndrome, where once you're awakening, especially these younger folks, have a tremendous reflex to breathe. True of all these ARDS patients coming in, the reflex to drive that inspiratory capacity, to drive the transportal pressure that's going to injure the lung, is what we stop with paralytics. But you don't need to completely paralyze the patient to do that. You can clearly partially paralyze to allow even movement of extremities, eye opening, but enough that you can control the spontaneous tidal volume. An older proof of concept paper from 2017 looked at CPAP, pressure support, or NAVA ventilation initially, with RASS goals of -3, and an attempt to either intermittently give rocuronium or continuously, and drive your inspired volume down to the 6 mils per kilogram ideal body weight, very successfully. In essence, we kind of do the same thing now by titrating to decreasing excessive inspiratory effort, titrating to keep a patient from being tachypneic. And so I prefer, as a pressure control, 15 driving pressure is thought to be reasonably good. Whatever the best optimal PEEP is in those patients. This is before they get to ECMO or after I'm weaning them from ECMO. And in an IMV mode where I'm driving the rate, but I've got a high pressure support that they can add on to. And that way you're preserving more diaphragmatic function. They're driving the inspiratory time. You're less likely to get into diaphragmatic atrophy. At the same time, you're not going to stack breaths like you would in volume control. So in weaning these patients off, that's been a pretty successful mode. There's much less air trapping, much lower mean airway pressures. As far as sedation and awakening, I mean, I think that the problem, everybody agrees, you can't slow their breathing with sedative drugs. You really do have to introduce some degree of paralytic to adapt to that. But then over time, I think a lot of this reflex is lost, and you're able to awaken sit up at the edge of bed, stand, begin to do bed exercises. And given that we're running these patients for weeks and weeks and weeks at a time at bed rest, it's critical to do this. Too often, 3 months later, I have somebody with major muscle atrophy, joint, they can't move. It's a huge process to get to being mobilized. And that being said, if you have a young patient that you know is their exit strategy, one exit strategy is lung transplantation, they need to be active to get that lung. And that's part of the drive, I think, in terms of mobilization. So we've been able to ambulate a femoral VV, stand, mobile, and move around. But if you can move towards a bicable, so much easier, but we have them walking 60 feet. I think we can talk about some of the other aspects of drugs themselves, but what we try to avoid are the vasodilating sedative drugs. Just because you're going to drive a higher cardiac output that you can't chase with the flows on the ECMO. And too often you see patients being treated with large doses of midazolam or boluses of midazolam because of hypoxemia, and then see a further drop in oxygen saturation just because you're increasing their cardiac output. So we tend to stay away from Seroquel as a dopaminergic. Meaning Seroquel predominantly hits dopamine receptors as opposed to serotonin, and as an antidopaminergic drug, tends to vasodilate, tends to cause more hypotension than, say, other neuroleptics like Zyprexa or olanzapine, which is mainly serotonin. So we've had a lot of good luck adding those things on, sometimes long-acting opiates, methadone even, and then trying to wean off the vasodilating and amnestic sedative drugs, such as the benzodiazepines and propofol. So that's kind of the second thing. I'd be interested to see what people's experience is. Third is anticoagulation strategy. We've gone towards lower levels. I mean, our basic range we try to work within is 45, 65. We try to avoid boluses of any kind. We can do 10 A's with a two-hour turnaround, so 0.4 to 0.8 would be a goal when we use that, but not very often. Usually it's just following PTTs on heparin. And because there's such poor correlation with ACTs and your PTTs, the ACT is usually used up front during the cannulation side of things, but not for management. That said, it's very hard to know what is happening with the coagulopathy based upon what we can measure. And I think it's really unpredictable who's going to get intracranial hemorrhage. But we've seen the spontaneous subdurals in 30-year-olds. We've seen very small venous subarachnoid hemorrhage. We've seen intralobar intracranial hemorrhage. And it's more than 7% in our population. And so I'd like to see what approaches people have had. But one of the major problems has been the coagulopathy driven by COVID that is turning into a DIC. That is to say, you've got a level of consumption even where their own fibrinogen levels are falling below 150. And then factor replacements required to continue to manage ongoing bleeding, either from trach site or pleural, sometimes even retroperitoneal. In terms of the real morbidity, mortality around the ECMO patients, it tends to be hemorrhage. It can be stroke related, or it can be stroke that converts to hemorrhage, bleeding in other areas, and then overwhelming infections. We've had a few cases where of aspergillus, invasive aspergillus, in 2. And these are, again, diabetics who may have been uncontrolled for long periods of time, but I think the diabetic population going in is the real consideration because of the type of infections you have to deal with. Fourth is the phenomenon of RV dysfunction. How much are we creating by the return from ECMO, trying to drive higher flows to keep up with the patient's cardiac output? How much is really from that complete lung rest that presumably increases pulmonary vascular, afterload? I don't know that it's truly the virus related, because you can see it so well with the LV being completely preserved, especially in younger people. And I think it just has to do with just how fragile your right ventricle is in certain states of overload. And then the patients that we've had that you'd put, swan and take them and give them inhaled nitric oxide, very reversible. And these were not from multiple pulmonary emboli. This is something that we saw a really good response to INO. Some of the patients still on sildenafil, with a continued response, but also not, 2 months out, still not resolving. So I'm not sure I understand what has really happened to the ventricle, why it doesn't recover as easily. So the other question is, are we seeing patients who had no pulmonary hypertension coming in, who were young, who went on ECMO, who were managed this way in terms of complete lung rest, and then continue to have to be managed for their pulmonary hypertension? And how many people have had to go in and actually vent the RV or try a different strategy in terms of, say, like a Protect Duo, which would just bypass the RV? Some of our cases, we've had to go to VVA in order to deal with the level of RV failure. So those are the 4 little things I'd like to try to discuss.
I got the answers to all of them.
Well, I know Davis has them because they'd spent the last 3 weeks talking about this.
Christian.
Yeah, that's it's ironic just how we parallel our lives, and I don't want to take up too much time talking. We can let Dr. Black get ready, and he might even have some slides to share. But certainly the issues around intracranial hemorrhage and optimal anticoagulation and running lower anti-10As is something we've really been focusing on, I'd say, the last 3 or 4 weeks. A big issue for us because we're very limited with our resources and the amount of patients we can place on circuit. Has really been optimizing the transfers we take. So that has been a big challenge for us. Like you, we have a team-based approach. Our pediatric colleagues were the original ones who established our program here, years ago, and have been the true experts. So we often will bounce ideas off each other and make sure that we are, when we're declining a patient, it's done so appropriately. And we do include non-invasive mechanical ventilation as time on ventilation, as you mentioned. And then certainly, and lastly, how do you walk these people? How do you take care of these people? What's the best way to sedate these people and wean them? And with that, Hugh, if you're off mute and you're able to chat, the floor is yours. And he's, Dr. Black has also been, I've roped this poor guy into both working a lot with ECLS, but also with crisis standards of care, because as I do the surge response and as I get older, my brain works less and the amount of jobs I have increase, and that's a bad prognostic feature for everyone. So Dr. Black has been a great savior. So if you're ready, Hugh, it's all yours.
Well, thank you. I think what I'll do is just talk a little. I think I'll just try to address each of those questions without having great answers myself. I think the first question with regards to lung rest is that's one of the ECMO questions, right? How do you optimally rest these lungs? It's sort of the, if you don't have it standardized across a randomized controlled trial like the Aeolia trial, right? It's very, very difficult to figure out whether those outcomes are different. I'd say that at Davis, we tend to just do sort of 10, 10, and 10 standardly. So we keep people around somewhere between 10 to 12 of PEEP. We give them a rate of about 10, and we try to minimize their driving pressure and their tidal volume. And historically, that's worked pretty well because over time, right, as you know, as the lung heals, it just sort of like bloop, just pops open, right? That's what often happens. One of the things that's been very difficult is that's not something that I regularly see in the patients that we have on ECMO. A lot of these registries, the ELSO registry, and I think the French study that was done in patients in the early days of the pandemic, the average run was 13, 14 days. That's not something that we're seeing. That may be because those folks were cannulated early, especially in France. They were not only cannulated early in their ICU or in their intubation course, they were cannulated within 8 to 10 days of symptom onset, which is very, very different from what we've experienced here at Davis. One of the things that's very difficult for us to tell is how you do optimally rest these lungs, because I have a feeling that some of these folks that we're putting on already have a fairly significant amount of fibrotic disease. And I think that's one of the reasons why you end up buying a lot longer times than you'd prefer. I do consider non-invasive ventilation to be mechanical ventilation in these patients, but it's not completely clear to me that it's the same. And so we've tried to limit the number of days on true mechanical ventilation or invasive mechanical ventilation to somewhere about 5 to 6 days rather than the 7 to 10 day range. We've also tried to limit some other things, including age, as well as obesity and BMI, because we really feel like we were sort of outside of what ELSO and other programs that have a lot of success we're doing. But the real question is, when you look at these folks, do you think that they have lung injury that's reversible if you just give them time and steroids and rest and otherwise good critical care? And I think that's a difficult thing. That's a lot harder to assess in my practice than it was with other diseases. I think that the pattern of recovery from this is just very, very different from what we're used to seeing. And I think that it has a lot to do, might have a lot to do with a lot of the vascular change and the remodeling of the vasculature that I think happens in these patients. And so we tend to try to just sort of rest the lungs as much as possible. But I find it very difficult to recognize recovery in these patients, when all of a sudden their tidal volumes pop right back open. That's just not something that I feel that we see. My guess is that we don't have anything near the numbers that folks down in San Diego have. We have about 12 or 15 people that we've put on. The second question with regards to how to optimize the sedatives. One of the things that we've been trying to be an advocate for is earlier and earlier tracheostomy on these patients, because we wonder whether just removing that stimulus in the upper airway, just the ET tube itself, might be something that might help us, because we do think that there's a lot of coughing. That's a struggle. I like the idea of these kinds of half-dose rocuronium, low-dose rocuronium boluses, rather than having people on infusions for prolonged periods of time. But I will say we're still on a lot of sedative medications. And as we come off, we work to get people more onto dexmedetomidine more than anything else. And occasionally we're starting to use a lot of ketamine. Only worry that I have with ketamine is blood pressure and potential cardiac output problems that were mentioned previously, because it's hard to capture the cardiac output of a 30-year-old who's on ketamine with a pressure that's that high. I hadn't really thought of Zyprexa versus Seroquel or those kinds of agents, and so that's very, very useful. The next question was anticoagulation and head bleeds. We also have had problems with bleeding in the brain here at Davis. And looking through that literature, it struck me, and it's not a very big literature, because it's really documented as about a 6 to 7% complication, both pre-COVID and in a lot of COVID, a lot of the post-COVID stuff. I mean, the ELSO registry documents a 6% head bleed rate, and we're talking about 1,000 people in that registry, but we know that we're not alone. There's a number of places that have had this problem, and they've looked at a variety of different solutions. The University of Pennsylvania, I haven't been able to get through to those folks, but they started having people on just subcutaneous heparin and aspirin, and I'm not sure how successful that's been for them, simply because there's so many problems with thrombosis and fibrin formation and circuit changes, and I mean you end up putting Fogarty catheters down these cannulas.
I was going to comment that because of the hemorrhage, now we're running a bunch of people dry off heparin entirely, right? And go weeks and weeks, and still see a bunch of clot in the membrane, but my post-oxygenator O2 is still looking good.
Yeah.
And this is one more peculiar thing about their own coagulopathies, right?
Yeah.
So I'm seeing a lot more bleeding, partly because of procedures, than we do in terms of thrombosis, in terms of the number of pulmonary emboli or vein thromboses peripherally. We don't see as much as I do the alternative problems with coagulopathies. So that the Pittsburgh thing was very interesting to be able to compare just sub-Q and aspirin versus low rates. But the lowest we can go with heparin is kind of been our approach. But I have a number of patients who we have not, are weeks, and they're doing all right.
Are you able to get really good flows on your circuit? Because we find the blood is quite thick. We actually have problems with our venous cannula pressures because of that when we're trying to get our flows up to 4.5.
Talking about outflow from the patient, or are you talking about return to the patient?
From the patient.
From.
Yes.
Yeah, it's great when you can see the negative pressure, right? And you can work with that, because then at least your RPMs you can adjust and know what you're doing. And bigger cannula, this is why we do fem predominantly, and 25 if you can get it, but not as much. Really, it's once you've gone long rest and that patient's not pulling so hard as to get a suction event on the outflow, and that's where we titrate our paralytics really, and we don't dry them out so much either, right? Yeah. But also living with PaO2s in the 40s, 50s, SATs in the 80s. I'm not looking to get somewhere around, I'm not looking at my consumption delivery ratio so much as I am urine outputs. What does the skin feel like? And what are my lactates doing? And then, so all you do is you kind of look towards that physiology that allows that lower one. And then it's not so much the flow back as it is keeping up with their cardiac output. It seems like universally we have on beta blockers without problems in terms of oxygen delivery. And propranolol, once we're committed to it, just as another anxiolytic. Almost everybody has to go on that. So avoiding vasodilators, beta blockade when you can use it. Not so much problems with chatter and all that other stuff in terms of, it's very rare that we are giving volume for that. It's more often it's the decision around, do you really need a hemoglobin of 10? Is 8 okay? Can they live below 8? So when we've done every strategy, when you've done, 2 oxygenators, or now you got another cannula for return, you went through all that, then I'll bring you up to 10. But sometimes that makes a difference. Right. So I think from going to the oxygenator, we've been luckier. I'm not sure, it really hasn't been that big of a problem.
One of the things that we've already also looked at, and I think that I've seen this in at least one of our intracranial hemorrhages on review, is what you've noticed, this kind of falling fibrinogen, particularly this kind of rising D-dimer and falling fibrinogen. It almost, when you put them together, it looks like a crocodile's mouth opening up. And I've wondered whether there are some groups that are suggesting that in that set of circumstances, particularly if you have a long lysis time on your TEG, that you might want to actually add an antifibrinolytic while anticoagulating the patient.
We use TXA. I've used TXA only on one, and that was when we had to do a craniectomy. Because the surgeon did a craniotomy, and it was subgaleal hemorrhage, hemorrhage within the space, having to go in for a full craniectomy. But even going to the craniotomy, we use the TXA. But on TEG, all these people, they're 0 on their measure of fibrinolysis, right?
Yeah, so that's one of the things that we've noticed so far, is even though you see that kind of that shift in terms of loss of fibrinogen, that the TEG still hasn't really shown me a whole lot of lysis.
Platelet, maybe I'll use it to say, like, I'm gonna transfuse for platelet less than 50, right? If they're bleeding or whatever. But if my TEG tells me that I've got a platelet dysfunction issue and I've got bleeding, then I'll give platelets in that setting. The rest of it, though, I find is really, if it's Kcentra or FFP or cryo, that makes a difference. That's how you stop the bleeding in those scenarios. And ultimately, it's weird to see these patients who normally their fibrinogen is 3, 4, 500 to all of a sudden drop below 150.
Right.
And that I think is the tissue injury that is on that scale that's driving a truly a DIC.
It's in like 3 days.
These aren't septic. These aren't bacteremic septic. This is DIC.
Yeah. And so that's we are predominantly a heparin program, and we shoot for 10A levels between about 0.3 to 0.5. Sometimes we go up to as high as 0.7, but I don't know that that's really changed our thrombosis problems or changed our need to switch out the circuits or any of those kinds of things. And then your last question is the RV. We've actually seen a number of people with persistent RV problems after decannulation. I don't know if you've seen that.
Yeah.
And I find it very difficult to get them off of INO without using Revatio, though we've been successful by really getting enough volume off of the person to be able to get them off of INO. But that took weeks. That took a long, long time. And I'm not sure how to protect the RV. I don't know that it's thrombotic, but I wonder if there's not a remodeling that happens. It's an awful lot of remodeling over a couple of weeks that would take a reasonably normal set of lungs, presumably, and then put them into frank RV failure without a whole lot of thrombosis. But I wonder if that's not part of the problem. I haven't noticed.
Your echoes do show RV dysfunction, right? I mean, the contractility of the RV isn't what it was.
Correct. Yeah, and we've had echoes, RV dysfunction. Do another point, put them on INO. Do another point of care. Well, look, that's better.
Well, I mean, I don't know that the movement got any better, but my mean pressure got a little better, right? I mean, now I'm 35, so. Right. But I don't know what that is. I don't know that's the vasculature or whatever. And there are a couple. Have you seen anybody with biventricular failure yet?
We have not put anybody on VA Ecmo, for example, for biventricular failure at this point. And I don't know that we've lost the left ventricle while on VV Ecmo.
We have not. I mean, I know of a case. I don't think so. I know of a case at Rush where they did an endomyocardial biopsy and clearly didn't show microcirculatory thrombi or any issue like that. It still fell into more of a viral myocarditis sort of look, although it really wasn't a diagnostic biopsy. And again, the only time we've gone from VVA was because of apparent obstructive shock and dealing with the right ventricle.
Can I answer the question, you guys? I think Christian, I think we picked the right guys. Huh?
Yeah. Much smarter than me, that's for sure.
Man, oh man, there are words that I can't spell. But what when it comes to me, I have 14 patients on continuous NIV for more than 48 hours on my wards, on my COVID wards, not in the ICU, but I think, Scott, you and I have talked about this before. What's happening up there is I'm going up and I'm seeing tidal volumes of 1,500, 1,700 minute ventilations that are approaching astronomical minute ventilations on these people on NIV. And I clearly think that those people should be counted as getting some trauma and be a mechanical ventilator day. But as you know, we're keeping them so long on NIV and we're counting them as ventilator days that when they get intubated, and then by the time we've mobilized everything, we're right at that doorway of your time commitment. And maybe it's us. We have to be more attentive. There are people also on NIV that are doing quite nicely with low tidal volumes and no stretch. And so, but there are those, I think maybe those are the ones that really should be looked at earlier, brought down probably to the ICU earlier, consideration for mechanical ventilation and low stretch, and then talk to you if they're a candidate. I just see that we're letting people get out of hand up there with these tremendous tidal volumes on these NIVs.
I think if you're going to manage somebody non-invasive, they need to be managed where you can really look at their expiratory volumes continuously, and you can do whatever it takes, if it's Precedex or whatever, that diminishes the reflux. But if you can't, then how many of those patients did not go on to be intubated? Didn't they all end up intubated?
In my hands, yeah.
And then how much fun was it after they were intubated? You know, those patients are the hardest in terms of, okay, now I'm just dealing with bradycardia and my SATs in the 60s and 70s, whatever.
With subcutaneous emphysema and a little medial tidal emphysema.
You've done some of that too.
Yeah.
But I think too when I compare NIV versus high flow, I see very often a patient doing better on high flow than they did with their NIV. I don't know how much we're really buying them. Now, to some extent, if that patient's really comfortable, or maybe if I'm treating something else than the COVID pneumonia, maybe I'm treating some degree of pulmonary edema or the management of COPD along the way. I think it has that role when you have a concomitant problem leading to respiratory failure. And there will be some, COVID pneumonias that kind of do okay with the NIV, who are comfortable with it, who aren't, don't have the excessive drive. But I think they're just better off on high flow in the long run. And I've seen them, I don't know what you guys' experience has been, but I've seen much better SATs going back to high flow off their NIV sometimes. And if they required you guys putting in an expiratory pressure above 5, bringing it up to 10, now what are we doing? We're just peeping the patient, and they're headed towards intubation.
I prefer high flow, but I think that you've put a very good, you've put a finger on a real problem with this decision making, which I don't think was present early on in the ECMO days for COVID. Because I don't think early on in the ECMO days for COVID, people were being maintained on non-invasive support structures for high flow nasal cannula for hypoxemia with the same kind of regularity as they are now. And what we've learned, what you've learned, what everybody here has learned is that a lot of them do fine. I think at our institution, hypoxemic respiratory failure with COVID is managed with high flow nasal cannula in 40 to 50% of patients that come to the ICU, and many of them do well, like a huge majority of them do well. And so it's finding those people that are not going to do so well, and then getting them supported with more invasive means relatively early, which I think is going to be the key to finding that patient population that will do reasonably well with ECMO if they fail those things. I think that's one of the tricky things about ECMO now as compared to what's happened in Europe and early in the US. I think that we've selected for a different patient population by having them be on these non-invasive means, but most of them do well on those non-invasive means. So I think that's a very, very tricky point. Some groups really say exactly what you're talking about, which is how hard are they working? If they really look like they're working hard and they have strap muscles and they have all that stuff and big tidal volumes, and they have that increased risk for what some groups think are self-induced lung injury, then that might be the group to move in, just like you say, earlier and support invasively earlier. Because I will say that I've seen an awful lot of pneumomediastinum and pneumothorax without being on a ventilator, aside from non-invasive ventilation. I can't say that I've seen that. I don't know what everybody else here, everybody else has a vast experience. This isn't just the three of us talking. I can't say that I've seen patient after patient after patient with pneumomediastinum after being on non-invasive ventilation or high flow nasal cannula. I've seen a lot of that, which makes me wonder what it is about this particular entity that puts people at risk for this? Why would that happen? I don't really know the answer.
But we had a readmission recently with huge pneumothorax, little potato for a lung. As spontaneous, just was at home doing normal things. So yeah, I mean, that's part of it. I think the other variable was dexamethasone, that there's something going on, bronchiolar or otherwise, that truly is responsive. And that's the other measure. So yeah, we got to them earlier before, but now we have all sorts of reasons to get to them late. So along the line of steroids, how often have you retreated later and seen a responsive, a diminution in pulmonary infiltrates in a patient where you put them back on and then taper them down? Because in the few that I've seen, they have not required prolonged steroid therapy like many forms of BOOP that you're used to seeing.
Right.
They and this is like older patients, 70s or so, who came in peripheral pulmonary infiltrates, worsening hypoxemia, back on steroids, and then see resolution. And they almost look like eosinophilic pneumonia because they're so peripheral.
Right. Yeah, that's interesting that they do look like that. I can't say that I've done this maybe 3 or 4 times in folks. Usually when they bounce back in the ICU, you worry more about that there's some kind of new infection or there's a hospital-acquired pneumonia or something like that. It's been a fairly high bar for me to restart steroids on folks, but that's a question for the larger group. I'd be interested to see what other folks are seeing with regards to that. Maybe there's an answer in the chat. Sandrock, do you have any thoughts?
No, I mean, I'm very much like, you, Hugh, and Scott. We've had a couple small instances where we've restarted it, but in general, most people have done reasonably well. When they've had this sort of waxing and waning course and they've generally done worse, it's been something else. We really haven't had the need to restart them on steroids. If anything, it's sometimes been, some laxing and anticoagulation. I found that to be more of an issue probably than any infiltrate. So if we've, maybe they go out to the floor and their, anti-10A dips down to 0.1 and we miss out and their D-dimer goes to 10,000 again, and then they come back to us. That's been more of an issue actually than I've seen the need for steroids in my experience. But yeah, I'd love to hear from the group if anybody else has any thoughts or, and I know might be some pediatric colleagues on that also do ECLS. Anybody with any input, that would be great.
I had just a couple other comments of things that you had referred to earlier. One was de-escalation of isolation. And we've been using cycle threshold for what it's worth and 2 tests and all kind of thing. Yeah. But typically, we're bringing them out of isolation at 21 days. And I'll go in with an N95 if I'm doing any kind of procedure, right? But in the main, that opens up nursing care to such a much better level, right? To get beyond the PPE side of things and to be able to have a little better access to that patient when it comes down to sedation strategy and awakening. So de-escalation of isolation is hugely beneficial. Secondarily, in terms of what limitations we have for patients' families to make visits. They don't have, you don't, how you deal with that, but, in our county, it's sort of 2 visitors for a short period of time and only once during that day. And then if they're full PPE, they have to dress full PPE, and somehow or another, we got to teach them how to fit their N95. So there are real limitations for visits, but de-escalation is really beneficial. And the second thing was in reference to ECLS. One of the early things we did going into this in April was suspend our emergency department ECLS, with the exception of the ED physician had the opportunity, if they saw young enough with a reversible metabolic problem, and that meaning, hyperkalemia and somebody who arrested because of that. Something very straightforward where you knew that either they arrested in the ED or they were in transport and their lactates, are 10 maybe, but reasonable to show that whatever chest compressions they're having during that time were adequate, then we would it was up to them to make an exception. But in general, we suspended ECLS throughout our 5.
Yeah. No, the ECLS, Hugh can mention that, but the ECPR side, we really have limited that. And if, again, like you mentioned, I think the last few I've seen out of the ED have been hyper or hypothermia, and that's been, and other metabolic derangements, which has been the correctable portion. Now, what the 2 testing versus reversal of isolation, this has come up because if you read the CDC guidelines for severe disease, which, you know, obviously all of our patients are going to fall into, you know, you generally have to have, you know, greater than 20 days from symptom onset, no fever for greater than 24 hours, and then what they would consider improvement. But when you have someone in ECLS or they're mechanical ventilation prone or moving around, how are you going to define improvement? And as you know, our patients constantly bounce around with fever. So if they hit, you know, 38.1 one day or 20, you know, 37.9, is that considered a fever, or is it always traditionally?
You can control their temperature on ECMO. That's not a problem.
Well, at ECMO, yes, that's true. So yeah, then that's a whole other side of control.
They don't get febrile.
Yeah, if they're not, you know, that ends up being, you know, if they're not on ECMO, that's a whole nother issue. So we then run into this problem where, and, you know, as you guys know, the big push for us has been limited reagents. So we're sort of hitting our back, as most places are, that we just, particularly with our, you know, GenMark and our LIAT testing, we just don't have the reagents. So we want to be very judicious with our use. So, but many of us in the ICU side want 2 negative tests. So this is the wall we're kind of running against because we don't fit the traditional CDC criteria, but we fully agree with you. Lifting isolation, not wearing a PAPR, getting immobilized, getting improved sedation, and being able to run in the room, you know, when their RAS hits 0.2 and you can sort of talk them down and you don't have to snow them every time. These are things that really help us. So that's, you know, we're sort of struggling with that right now, is getting everybody on board to really either buy into the non-testing approach or figuring out a way that everybody's happy. And that mostly ID writes a note. So infectious disease and infection prevention writes a note what to do, but you can imagine some people don't like that. They reject that idea. And then how do you adjudicate that? So it's been a battle.
Yeah, when you have a transplant patient or a rheumatologic patient who's been on immunosuppression and they're going through this little process, usually not on ECMO, but they're there. It's hard to buy into 20, 21 days and, you know, 100%, because you just don't know. And we've all been excessively protective for good reasons, because we just don't know. That's where, I don't know if there's real science behind the cycle threshold, but that's where we'll do our routine tests. In the main, throughout, we've been able to do a couple of routine tests and find that maybe they're in the 30s or high 20s for sure. I mean, that's a negative test as far as I'm concerned. So then, very, very confident with that. But tell you a story, right? Patient's been out of isolation for 6 weeks. We're going to decannulate. Somebody does a rapid test to determine whether or not to do it in an operating room or at bedside. Previously 2 tests negative. Rapid test comes back positive. And so they decannulated at bedside. It was very reassuring, you know, that that some of these tests, the patients continue to remain positive for months and months at a time. And that's what's problematic about test-based, right?
Yeah, and I think you raise a good point. You know, a cycle threshold above 30, the likelihood that that patient is contagious is extremely low. But the exception to that is the immunosuppressed. So there was that one paper recently, and I think it might have been Lancet, but I can try and find it, where they had bone marrow transplant patients. Their cycle threshold was relatively high, and they were actually able to infect cell lines, which is different than our immunocompetent patients. So you can maybe get a test positive at 35, 40 cycles. Good luck in getting that to grow in cell culture. But you can actually do that with some of these immunosuppressed patients. So that's where I think we do, for our immunosuppressed people, we do 2 testing. So if it's a bone marrow transplant, solid organ transplant, hematologic malignancy, we're doing the 2 tests. For most of our others, that's not the case.
You know, let me break in a little bit, and I you know, in terms of time, but I have to, since you're doing anecdotes, I remember I trained under Ken Mosier back in the day, and if you remember Ken, there was only 2 types of lung disease: steroid responsive and steroid non-responsive. And Ken also says you never die without steroids, and you give a hell of a lot of steroids. So if I'm going to restart steroids, which I do, and I know that 6 milligrams of Decadron is 160 milligrams of hydrocortisone equivalent, I'm going to give a higher dose of steroids the second time around, which now you've got my anecdote. And I'd ask people from the audience and online if they had any questions or if they have their own anecdotes. Anybody out there? You're all muted.
Yeah, We got a quiet group today, Denny.
Man, oh man.
Because you and I are talking. When Asha talks, everyone's vocal.
Yeah. Anybody
I
have
think Shazia had something to add.
Yeah, hi everyone. This is Shazia Jamil. I'm one of the co-chairs of Education Committee with Michelle Cow. And thank you, Asha and Denny and everyone else for having this forum. I just wanted to make a couple of points. We did a San Diego CME conference and we invited the New York University Hospital Ecmo group, and it was wonderful. It was virtual 2 hours just a few months back, and they had a really high survival rate. And one of the things that really stuck to me was their criteria for patients to be on ECMO. So just briefly, they were very, very strict about BMI. They would not put any patient who had acute kidney injury or, CKD going to AKI on ECMO. And then lastly, they were doing it within 8 days. So I just wanted to put it out and see how everyone else's experiences and their survival they were quoting was greater than 85%. And they had done, I don't remember quite well, but I think 167 patients. I mean, really a large number of patients. I'm going to go on mute right now.
The paper they put out some time ago was, I think, about 28 or 29, something like 25 to 28. And they had only outcomes on a percentage of them, and they were doing very well. And they were early cannulators within 2 days. And they chose people, I think that the highest BMI they had was about 34, or I don't think it was even that high. I don't remember them not leaning away from patients who had renal insufficiency, but they also rejected about 60. I actually think I have the paper. I can find it, but about 60% of referrals were rejected. So that's also something to sort of know. It's interesting that they've now backed that up with a lot more patients and still doing really, really well. They also, by the way, they also trach it, but they were traching it about 3 days, from what I can see.
I think, for our institution, 2 weeks is early trach, 3 weeks, but that is an important concept. It is, and sometimes it's hard to get the ENT surgeon too excited about it. So, an invasive pulmonary doctor is very useful in that situation.
Right.
I was in on that conference in New York, and basically the main event was they were early. The Bmi Paradox in ECMO, I mean, it's a thing, right? I mean, when you really look at the folks who are in the 35, 40, even 50 range, their time to decannulation was very, very similar, but their survivorship was greater. That was the last absolute exclusion for us, was BMI. At a certain point, it's just how do you manage the patient? How do you examine them? All the limitations what go into managing an obese patient become considerations, I think, in terms of whether to take them on. But for ECMO per se, if they are built well enough to manage, we've taken some folks in their 40s and done okay.
Do you have trouble capturing their cardiac output?
A little bit.
Asha, anybody else in the pew?
Yeah, we have a few minutes left, so it's a good chance if you guys have some questions, issues, concerns, feel free to ask all these smart people, which is wonderful.
I was interested in hearing about supplies and shortages of that. Is that limiting things for folks, or if they're struggling with that? Are you guys sharing supplies with ECMO, or?
We're not sharing any supplies with any other programs, but there's not very many programs that are near to us. But we haven't had very much problem in the way of supplies. It's just sort of numbers of circuits and circuit availability that we already have.
Quiet.
Well, thank you, Denny.
Yeah, no, this is set up to be your time with people that we feel can have some of the answers that they need. We promised we wouldn't ask them their outcomes, so we won't. So there you go. But so I think I won't go there. Anyway, it's great having everybody on. I've been looking at people I know, and I think this is a great forum, and we'll try and have good topics going forward. And that's all for our leader, Asha. Appreciate it.
So, well, thank you very much. Thank you all, Dr. Black, Dr. McCall, Christian, Denny, everybody in the chat group who's added literature and opinions. I think it keeps the session mixed and interesting, and we'd love to know what your thoughts are for next week. As with COVID, every day feels like a month, and then there's always something new happening. And so I think our topics are going to be driven by kind of what's hitting the headlines. I would love to encourage our Los Angeles colleagues to inform us as to their experience, so that I think we'll focus on trying to get them on board for next week, to see how we can assist them, support them, and learn from them. So with that, I would like to thank everybody who has participated, who, I mean, 50% of the group, or even 3/4 of the group, has hung on even beyond our hour. So this is an excellent conversation that Scott and you have had, and I really, really appreciate this. And thank you all. And have a good weekend and stay safe, everyone.
Thanks, Asha. Thanks, Denny. Thanks, Scott.
Thank you all.
Thank you.
Really enjoyed meeting you guys.